Hello and welcome back, everyone. What a phenomenal day we continue to have, learning from leading experts, tremendous discussions, and continuing our theme of using digital as a powerful tool in the toolbox to, and I'm just going to adjust the screen here. I think it's a little strange. We'll have to work on the view. Thank you for your patience, everyone. Just tremendous discussions through the course of today, both from external partners, internal innovators, voices of veterans. We're all here to serve, and just absolutely delighted to be having this conversation with you all. For our third and final session of the day, I'm delighted to welcome Danielle Hagan to moderate and lead the discussion of a variety of different use cases, and then a panel conversation considering how we can successfully disseminate centrally driven innovation. We've learned about local innovation. We've learned about how we partner with external vendors. And Danielle, I wonder if you can go ahead, introduce yourself to everyone, and then we'll hand this final session over to you to lead us through, to guide us, and to learn. Thank you so much.
Great. Can you hear me all right, Jennifer?
Yeah, we've got you clearly. Thanks, Danielle.
Perfect. Thank you. As Jennifer said, my name is Danielle Hagan. I'm a diffusion specialist within the Diffusion of Excellence program within the Innovation Ecosystem at VA. I'm really delighted to be here today. I'm especially excited to lead this session on how we go about diffusing these practices that we work so hard on. It's an art form all on its own. But today we've seen how local innovations are identified, polished, and scaled. We've heard how we're working with industry partners to further our innovation. And now I'm really excited to again talk about how we actually make all of this happen behind the scenes and engage with our veteran representative to see how things work on his end. So next we're going to be hearing from a team of experts who have worked to diffuse national projects throughout the enterprise. We're going to hear what their journey was like, the good, the bad, and the ugly with all of it, and how they go about getting these processes across the finish line to ensuring their sustainment and the use of these skills. It's just imperative to innovation. So the technological aspect of this is all just one piece of it, but the work behind the scenes is really the heart of all of this, between VA firewalls, permissions, security, privacy, all of that kind of stuff. So I would like to kick this off by introducing Shane Elliott, and he's going to be telling us his story in action about using VEText to increase healthcare for all veterans. Shane, I'll hand it over to you, and if you'll please introduce yourself and then go right into it.
Thank you very much. Sorry about that. All right, so my name's Shane Elliott. I work for the CTO's office. In the CTO's office, I work on the health products team, where I work on improving the experience of both veterans and clinicians as it relates to healthcare. But before that, I was the associate director for the Loma Linda VA Medical Center about a year ago. And there I led a team to innovate and develop VEText, which is now VA's text message appointment reminder system. So I'm going to talk to you today a little bit about VEText, give you an overview of where we've come from, and also add a little bit about some of the most recent innovations we've been able to do as it relates to COVID. So as I mentioned, VEText was deployed or developed in Loma Linda around 2016. I actually had to look that up to address our high no-show rates. We're experiencing high no-show rates, and with high no-show rates, that decreases the efficiency of clinics. And we were trying to find a way to decrease that to improve our efficiency and see more veterans. We worked with So what we did was we developed an appointment reminder system that uses a software gateway that sends appointment reminders to veterans and reminds them of their appointments. But not only does it remind them of their appointments, but allows them to cancel their appointment if they can't make their appointment. We deployed that in Loma Linda and had a high success rate. There was a lot of interest from many other facilities. And along with the assistance of the Innovations Ecosystem, it diffused to 11 other sites pretty quickly. They experienced the same success rate of decreasing no-show rates. Pretty soon after that, the Office of Veterans of Access to Care got interested, along with the Chief Technology Officer's office. And with their assistance, we were able to deploy this nationwide. In 2018, it was a decision by the OVAC office to make VEText the official SMS appointment reminder system. and we were asked to deploy it within 4 months. It was a lot of work, but we actually got VEText deployed nationwide within 4 months. So today, VEText is deployed and active at every VA medical center. Along the way, we ran into many different challenges. One of them was the ability to display the clinic name in the appointment. There was a determination by privacy that anything more than just one piece of PHI, which would be include the clinic name, the date, time of the appointment, that was considered a sensitive message and could not be sent without some additional processes. And we had to work with them to develop a process that allows us now to send both PHI messages, including clinic name, which makes the message a lot more useful to the veteran, and also non-PHI messages if the veteran chooses not to enroll in the PHI process. We also had to work with the assistance of the CTO's office to attain our own ETO. I think I've heard mentions of ATOs on other calls. It was a very challenging process, but with the support of the CTO's office and OVAC, we were able to do that. After deploying appointment reminders, we noticed that we had a great no-show rate, improvement in no-show rates. But when we looked at the data, we didn't increase adherence or increase the number of veterans that actually came to their appointments. What we were doing was enabling veterans to cancel their appointments when they knew they weren't able to come. Well, that's a great thing. We want to know when veterans can't make it, and that way we can make reuse of that slot. So we started talking about, well, how do we make reuse of those slots? And we developed something called open slot management. Now, what open slot management is a solution that identifies open appointments, not only the ones canceled by veterans, but any open appointment, and then looks for veterans waiting greater than a defined period of time. For example, 30 days. So if I can identify a veteran that's waiting greater than 30 days, it then offers that earlier appointment to the veteran. If they agree by text message, this is all done by text message, we'll go into the VISTA system of electronic medical record, change the appointment to the earlier date, cancel the older appointment, and relink the consult to, if there was one, to the earlier appointment. So this was a great process that improved access. We actually found if you add up all of the, I'll show you some other data in a minute, but if you add up all of the wait time that we saved so far by scheduling earlier appointments for veterans, we've saved over 5,000 years of wait time for veterans. An additional addition to appointment reminders was something called NIRMO. We found that NIRMO is another initiative that was out there called the National Initiative to Reduce Missed Opportunities. And what they did was to develop an algorithm to predict the likelihood that a veteran would come to their appointment or no-show their appointment. And it gave a probability. So we were able to integrate with NIRMO. And now we send an additional message the night before the appointment with wording targeted at making sure the veteran knows it's okay to cancel their appointment. That way, if they know they're not going to come, and they can cancel their appointment. So since we moved to the CTOs, along with me moving to the CTO's office last year, we actually moved VEText over, and now I product manage VEText nationwide. Since then, we've had additional use cases. We've had other people approach us, and with the support of OVAC and the CTO's office, we've been able to provide appointment hearing reminders for veterans that have a Board of Veterans Appeals hearing. We've also enabled mass messaging for multiple things. One we'll talk a little bit more about later, which is COVID-19 messages. We've also sent out messages notifying veterans it's flu shot season, etc. We've integrated some AI. We found that when veterans replied to the messages to either confirm or cancel their appointment, sometimes they weren't using the actual code, but using some other kind of word or some other message. And sometimes they actually asked other questions like, how do I get to the VA? So we've implemented some AI that tries to identify or interpret the responses and provide back a response to the veteran. In addition to just confirming the appointment or canceling the appointment, we can provide additional information like directions to the facility. Now we're piloting some other things, veterans retention. We're sending messages to veterans that are at risk of dropping off of their primary care panel because they haven't been seen in a certain period of time. We send those messages to veterans and offer them an opportunity to call the facility and schedule an upcoming appointment. One exciting thing that we're actually working on right now, we're actively piloting in 2 sites, and hopefully we'll be deploying nationwide as well, is shipment notification. So one of the largest complaints from veterans is they don't know where their medications are or when they're coming. So at 2 facilities now, we're sending a notification when a medication is shipped from the local facility that includes their tracking number. And we've had a lot of positive feedback from veterans, and it's actually improved the trust score for those facilities in the pharmacy measures. We've developed an API that allows other products to use the VEText messaging system. We're working with the behavioral health laboratories and sending messages for them. And we're also working with the CTO's office for an enterprise mobile app that they're deploying, and we'll be handling the push notifications for that. This last year, we developed surgery notifications. So now we have a product that staff can use to communicate with their family while the veteran is going through the surgery process. Family members can just come into the clinic and register with that veteran and the MSA. And then the clinical staff and the MSA can send messages to the family members, letting them know the status of their veteran as they go through the process. We've also enabled clinic cancellation. This was a request related to COVID and also for natural disasters. We've developed a way for staff to cancel an entire clinic and then send messages to the veterans notifying that their appointment was canceled. This has been used in many of the natural disasters last year, and it was used during COVID. We've also developed a few solutions related to COVID that we had to do pretty quickly, and I'll talk about those as well. All right, so this is some information on the results of VEText since the beginning. As you can see, we've had before COVID, we had a 12% overall improvement in the no-show rate nationwide, which was the lowest in over 2 years until COVID hit. And as you can see, the numbers on the right, everything went out the window when COVID hit. We've been able to communicate with over 7 million veterans. We've sent over 200 million messages. We've been able to cancel over 4 million appointments. And we've been able to reschedule over 45,000 appointments. And those are the appointments that led to the savings of over 5,000 years in wait time. Recently, we've been working on directly scheduling appointments via text message. That is done, a process that does not include a VA staff member. We offer an appointment to a veteran. The veteran can reply with a date and time of when they'd like that appointment. And then we go into the electronic medical record and schedule it. So I'm going to talk a little bit about some of the COVID solutions that we've developed over the last year. Once we moved to the CTO's office with the support of OVAC and the CTO, we were able to quickly innovate and help with the VA's mission towards COVID. In the beginning, we sent 5 different messages to over 7 million veterans, letting them know about the VA's mission and what they're doing, what we're doing for COVID. We were able to reach or send over 39 million text messages to veterans and reach them and get critical information to them early on to let them know about what the VA is doing towards COVID. When COVID hit, facilities closed down, and there was, and as we know, many VAs have small waiting rooms. So there was a need to find a way to better manage the veterans that still needed to come in and get care. So we were asked by the facilities to help, and we developed a product called I Am Here. And what I Am Here does is allow veterans, when they get to the facility in the parking lot, is to text here, the word here. And what happens is the staff in the clinic is notified via the VEText portal that the veteran is waiting in the parking lot in their car. And then the staff can send additional messages to the veteran. First one sent to them, letting them know, thank you for letting us know you're here. Please wait for further instructions. And then the staff in the clinic can use the VEText portal to notify the veteran when it's safe and time to come into the facility. This allowed facilities to improve or enhance physical distancing during COVID and make sure that they're tracking the veterans as they're waiting in the parking lot. Once COVID vaccines were available, we were asked to assist with communicating with veterans related to COVID vaccines. We developed 2 different solutions. The first solution we did was what we'll call a one-way solution, where we're notifying veterans it's time or that vaccines are available, and if they'd like to schedule, to please call the facility, and we provide a phone number for them to call. Then we developed a direct scheduling solution. I mentioned a little bit about that earlier. But what direct scheduling is a way that we reach out to veterans. We tell them we at the Loma Linda VA Medical Center now have COVID vaccines available. If you'd like to schedule an appointment, reply with a date time that you're available, And when the veteran replied with the date time that they're available, we then went into the VISTA system with the electronic medical record, found the appointment closest to the date time they requested, and responded back to the veteran with that information. So we're able to schedule appointments completely without VA staff involvement, saving staff time and improving efficiency in scheduling appointments for COVID vaccines. With these two solutions, we were able to facilitate over 750,000 appointments for COVID vaccines, and over 230,000 of those were done through direct scheduling or no involvement from VA staff. And then we added, if you're not aware of the COVID screening tool that the CTO's office also developed, that was a tool that allowed VAs to automatically screen veterans as they're coming to the facility. We also added that to the text messages that we're sending for appointment reminders at the end, or as they were coming in to see the facility, they were able to click on the message in their appointment reminder and launch the screening tool. Well, that's an overview of VEText.
Thank you so much, Shane. I really appreciated your insights there. I've been in VA for about 10 years, and I remember when VEText was first being talked about, and I think it just really speaks to, you know, innovation seems like such a really exciting topic, and it is very exciting, but I think people forget that it's a long haul and it can be exhausting, but you're still so excited about the project. So I appreciate you sharing your story with us and sharing the journey that this has gone down toward and how you've also flexed it to accommodate COVID. So a really great story. Thank you for sharing. Next, I would love to introduce Dr. Rachel McCardle and Brian Stevenson as they share their story with us, an enterprise remote tuning of hearing instruments, or as you will hear them refer to it, ERTHI. I'm going to turn it over to Brian first.
Well, we're going to talk about enterprise remote tuning of hearing instruments, and I'm just going to start it off, and hopefully Brian's mic will be working because he's doing the bulk of the presentation. I'm just going to tell you what it does. And enterprise remote tuning of hearing instruments, in audiology, we've been doing telehealth since 2008. And so we were really looking for a solution to be able to reach into the veteran's home. So we started this project way back, and Brian's going to go through the timeline. In the end, what it allows us to do is the VA audiologist is sitting in the medical center, and we're able to reach into the patient's home through either a tablet or their smartphone and completely program their hearing aids. We can change their programming, we can add programs, we can make changes. We have 5 national contracts for hearing aids in VA, and we spend over $300 million a year on hearing aids. Hearing loss and tinnitus are the 2 of the top 3 service-connected disabilities. So we have lots and lots of veterans who do come in for our services. We see over 1 million veterans per year. We have about 1,400 audiologists out in the system throughout the 18 VISNs and about 425 audiology health technicians. For us, we've been working with innovations for multiple projects, and we've had the pleasure of working with Brian on more than one project. And as a central office, so I'm the National Director for Audiology and Speech Pathology. Probably should have started with that. But we have, we're a policy office who identifies what can make it easy on the field. And so we have put the time in to some of these innovations. And it does take, we are probably the other end of the continuum, as we heard Shane Elliott's talk on VEText that he got to an enterprise level in 4 months. As Brian goes through our slides, you'll see that was not our story. But with perseverance, we have been able to push multiple innovations through the innovation ecosystem, and we continue to work. We have a new one right now that we're just getting started. And so it's been such a great experience for us. And marketing is critical for the veterans adoption. At that point, I'm going to turn it over to Brian.
All right. Can y'all hear me? Someone say yes. Are we good?
We've got you.
Okay, good. Yeah, I don't know what was going on there, but it's over now. So, hey, everybody, I'm Brian Stevenson. I'm the Associate Director of Emerging Health Technology Integration down at SimLearn at Lake Nona Medical City in Disney World. Well, no, not really, but Orlando, Florida. So yes, I've been with the innovation ecosystem for 11 years, And almost all of that, I got to hang out with Dr. McCardle on with Earthy. So Earthy, what you're going to discover in this short presentation is that Earthy really was a testament to perseverance and grit and overcoming insurmountable hill after insurmountable hill. And so this perception versus reality. Perception is that it was a highly complex product, that it, the 10 years was because it was so difficult to achieve. Actually, something that I just want to convey to you all, and most of you innovators realize this already, is if you're getting in the innovation business, while there may be technical process standards, security process standards, etc., for the norms, innovation does not fit that box. Okay, so you may be the first up to the bat for the first type of technology, and you're going to have to become savvy at listening in between the lines to learn to recognize when someone is answering your question with a guess or with an actual. And sometimes all anyone can do is guess because it's your first time up to bat. So real fast rundown, 2010 to 2012, not too many mishaps there. DishF was its first name. Earthy's had many names in its life cycle. That's distance hearing aid fitting. And it was an interim wearable device that was cumbersome, and connectivity remained kind of spotty in rural areas. But it worked. It was a proof of concept. We meant to pilot in 24 to 2016, but another thing to consider is when you are running up against other enterprise initiatives, we were excited to say, hey, there needs to be video and scheduling in this now. That's the missing piece for this hearing aid distance fitting app. And so we sought to sync up with VA Video Connect. We communicated well with their stakeholders. Also, the telehealth management platform, which was going to be deemed the telehealth platform for scheduling. Neither one of those groups were ready for us. And we pitted and we pulled and we tried. And not being a team to go quietly into the night, we decided to work more strongly with our partners, our industry partners. So two of the hearing aid manufacturers that we contract with were part of this new contract, and we did get video implemented. We did get scheduling implemented, but we had to call it proof of concept 2.0 because we couldn't impact VA writ large as we had intended with our pilot. But we were able to use a third-party relay system, Cloud Relay. Now, don't you know, when we mentioned that lit everybody up. Nobody wanted to talk about using third-party relays. Absolutely not, right? It's cloud first. Well, we were going cloud first, but sideways. So 2016, 2017, we went to the powers that be that were funding us, supporting us along. Innovation always did. As you all know, there are myriad stakeholders in any innovation. And in this hybrid environment that we live in today, there's usually more than one. So that office that was supporting us in that way didn't really know what to tell us as far as how to continue or where to go. So they let an additional contract to make a recommendation to us. At the end of all of that, it really came about to they thought that we were a COT SaaS product, and therefore we should go pursue an ATO through the COT SaaS process pipelines. So we spent 2017 to 28 doing that. We climbed all the way to the peak of that mountain only to be told, you know what, this isn't COT SaaS. You guys go pound sand. No, they didn't really tell us to pound sand, but they did tell us that it was a misnomer and we should have never gone through all of that. So after years of bloodletting, we almost lost our steam. But that was when we were so fortunate to bump into Miss Angela Gant-Curtis, who you heard from earlier. Working for the CTO as well as Shane Elliott, both really huge proponents and positive backing for innovation. That doesn't mean that Angela's just going to give us a get out of jail free card. No, she meant to make sure that we adhered to current processes, and she was there to mitigate risks. And most of those risks were misunderstanding. So a lot of times when we don't know what to say and we're maintaining a process, we'll hold people to a process, whether we're right or wrong, because it feels like a safe spot. And so thankful to Angela and others that she brought to the table that we began to create sort of a definition of terms, a dictionary of clarity as we started to go the right route. Long story short, let's pop over to the green area, 22 conclusions. we found out that Earthy, in fact, could be activated through a national memorandum of understanding or interagency service agreement for each vendor. Now, here's one layer of complexity for Earthy. Because there were 4 vendors and eventually 5 that each had their own remote tuning hearing instrument offering, we had to do everything times 5, right? So 5 MOUs, 5 POAMs, 5 everything. But we were ready. We were doing it. And COVID-19 started to ensue. We were getting nervous thinking we're not going to make it over the pipeline, but this could be used as a COVID emergency operation. Another exciting feature was we found that Earthy only needed to have its ports and application IDs whitelisted through the Trusted Internet Connection Gateway, or TIC Gateway. And finally, the real caveat was that these services, these remote tuning services, were available to the nation's veterans at no additional cost to the government. They were always going to be. It took us 10 years to provide this free offering to veterans because we weren't communicating clearly. And that probably falls on everyone's shoulders along the entire journey, including the project team. So essentially, we took 10 years of issues, boiled it down into a process. Once we realized, and OINT and OIS understood what we were and what we were about, and we all kind of were level-setted many years later, we were able to bring that 5th vendor on later in less than 6 months. So we shared that process with the powers that be. Sadly, it's still not been included in any kind of workflow, but it does exist. So anyone on the line who has a project that may have one of these 3 elements, if it's using a third-party cloud relay, if it's not transmitting or storing PHI or PII, and the devices are already under contract, there's a good chance that that service offering might follow suit with what we did in 6 months. So if you're interested and you're going through a similar situation, connect with myself or Dr. McCardle, and we'll gladly share our playbook that we developed for the enterprise for any other projects that might be in this situation that could leverage these capabilities. So how do we identify solutions to these challenges? We can't just complain, right? We have to fix the problem as we go. And so what Earthy taught me specifically, and I think others on the team and others from our stakeholder groups, was the old days of innovation, kind of running fast and T-boning processes at scale, are over. That's not the way we do business. And fortunately, through the strong work of Suzanne Shirley and Dr. Ann Bailey, Dr. Amanda Purnell, others that rolled out partnership agreements, CRADAs. We've written so many in the last 2 years. It really taught us how to partner. I don't know if we clearly understood that beforehand. So now what do we do? What does this slide represent? You've got to have the whole party at concept definition. You better have OIT and OIS, Office of Information Security, holding that shovel with you as you plant that innovation seed together. And what are we talking about? We're talking about technology innovation, right? Not process innovation. Those things are, I'm not going to say they're easy, but technical innovation is twice as costly, twice as expensive, twice as costly, twice as time consuming, and takes twice as much energy to climb the hill. So,
hey, Brian.
Yes.
Brian, for the sake of time, let's pick up some more of this in our panel discussion. Because I'd like our next storyteller to be able to go next, but I always appreciate your energy. You are a storyteller I could listen to all day. You just are so passionate about what you're talking about.
So I'll wrap it up in 10 seconds.
Yeah.
Don't burn bridges, build lasting partnerships, or you'll never meet the summit. The end. All right, we'll talk in a bit.
Yeah, I also appreciate your ability to play the long game. That's what innovation is playing the long game. So our next story in action is going to be presented by Dr. Cole Zanetti, and he's going to be talking about approaching digital solutions to improve mental health through quality improvement and discussing the difference between research and QI. So please introduce yourself to us, Dr. Zanetti, and then kick it off.
Sure. So my name is Dr. Cole Zanetti. I'm a family medicine and preventive medicine trained physician. Also the Chief Health Informatics Officer for Ralph H. Johnson VA Medical Center and a Senior Advisor for the VHA Innovation Ecosystem. So I'm going to be kind of diving into something that's near and dear to my heart. So in my preventive medicine training, I specialized in quality improvement and systems change. And there's always this sense of ambiguity of, what are the differentiators between QI and research. So I'm going to kind of speak to that today, and we'll be able to talk even more during the panel. So one of the key differences between QI and research is that quality improvement is really focused on sustained improvement versus single intervention effectiveness. So QI measurements framework is about continually measuring your metric of interest for sustained improvement, not proof that a single intervention is effective. The real goal is to cycle testing to continue to improve, and you're developing multiple interventions, or I should say, deploying multiple interventions informed by that testing. And the key feature here is that it's the actual system that you're wanting to improve. So I bolded out multiple interventions and the actual system because the core difference between QI and research is that QI is not set up, intended, its whole approach, the goal is not to be generalizable. It's specific to the health system or institution that it is trying to improve. This is a key differentiator because QI projects are not set up to address internal validity, such as confounding, bias, imprecision of design, methods, measurement, or analysis. So its goal is, once again, to create sustained improvement through learning and deployment of multiple interventions within a very particular health system. So this is a paper that I think reemphasizes these components and adds one additional feature here that really helps distinguish QI from research and where the line is. So once again, it's not built to be generalizable. It's focused on improving processes and practices within a very specific hospital or healthcare setting. It's not designed to try to be dispensed outside of that. Research, on the other hand, deploys very sophisticated methods to try to limit the biases and errors that I aforementioned so that it can be or may be generalizable to other patient population or settings. Another key factor here is that when you're conducting QI activities, the interventions are at least as safe as routine care, and all patients receive standard care. So in research, that may not be the case. When you're testing novel ideas beyond current knowledge and standard of care, you're not sure of the actual degree of risk. Sometimes participants may not get standard of care so that you can analyze the different arms of the study. So those are the key differentiators of QI and what makes it significant. And I'm going to just demonstrate, a QI project that we are working on here in Ralph H. Johnson, which is in current development, but I thought was a really meaningful example to share with y'all. So the VA is at large is trying to address high suicide rates in our veteran population. There's a known knowledge gap of not having information regarding veteran depression status once they leave the office visit or some type of healthcare interaction. We haven't been assessing where they are in terms of depression when they leave our centers. There are also occasions where veterans with prior history of mental health diagnosis are committing suicide. A 2018 longitudinal cohort study of enlisted soldiers documented that of those soldiers with documented suicide attempt, found no history of health diagnosis, mental health diagnosis, in more than 1/3 of those who attempted suicide. So there's evidence that there's a possibility that there are veterans out there struggling that we currently don't have a medical diagnosis of. We have data to support that within the VA too. there's also a concern that if we were to obtain information outside of normal business meaning, Friday evenings or Saturday or Sunday, we might not have the support staff to respond within 24 hours to address the need for care related to what's been identified. The aim of this project would be to utilize something called CareCentra, and I'll explain what that is. It's an app with veterans, possibly vets transitioning from military to civilian life, but still we're figuring out the particularities of the population to target, to better identify veterans with acute mental health needs and connect them with services and care in a timely manner. So CareCentra, so this is an application that runs in the background. Basically, it's downloaded. A veteran or patient answers questions about what motivates them, things that are meaningful to them, and it basically combines clinical data, social determinative health data, remote patient monitoring data, has APIs for all digital devices like Apple, Android, Alexa, things of that nature, and FitBit, and it actually deploys well-documented nudge techniques to influence behavior. But they're also sending questionnaires related to assessing current state. So the CareCentra app has been involved in 2 randomized controlled trials. And the one aspect I'm going to kind of hone in on is a mood check that was sent randomly to patients. It's also sent with increased screen time from baseline, which is well documented. 2019 systematic meta-analysis showing that association. But this is the simple component here. The timing, the type, and the frequency of these nudges are a continuous thing. It's not static, and it's customized for a personal algorithm for behavioral change that their AI is running in the background. But so the mood check, you see this, patient clicks on it. These were the results of the specific to this population of the randomized control trial. So 350 participants, 33% were sent the mood check, and after 3 consecutive responses where they were not feeling either sad or very sad, it triggers a PHQ-2, a validated tool that we have in clinical medicine, and 22% that it triggered the PHQ-2 of that component. 16% of the total population, or 56 patients, actually screened positive with a PHQ-9. If the PHQ-2 is positive, it gave them the PHQ-9 questions right afterwards. Now, a 15 or higher is severe depression. What I want to highlight here is the difference between the 10 and 56. So 46 of those patients that screened positive for severe depression never had any previous history of a coded diagnosis of depression in their medical record. 1.7% were actually screened positive for suicidal ideation in the PHQ-9, all of which had no prior history of any mental health diagnosis of depression in their medical record. So this captured this element of identifying people with needs outside of the office visit that we were targeting. These were some other components, evidence-based elements of these 2 RCT trials showing reduction in major cardiovascular events through the nudges of increased activity and medication adherence and compliance, weight loss, A1C. So there's definite other features as a part of this app in their nudges, but the depression one was the one we were targeting. So based on these 2 RCTs, I want to reemphasize this point. They were able to identify 13% of patients of having severe depression without any prior diagnosis of mental health in their medical record, and 1.7% of the population with suicidal ideation that had no prior record of mental health diagnosis. So what we're proposing is if the patient responds with a poor mood emoji. It's set for 3, but that parameter can be adjusted. On 3 consecutive occasions, a PHQ-2 is triggered. If it's positive for PHQ-2, a PHQ-9 is sent. If the patient has a 15 or higher, but no positive suicidal ideation, a message will be sent through CPRS. We are not using a separate portal. It is going to be pushed to the team through CPRS to the primary care provider and the nurse team via medical record. If the patient screens positive for suicidal ideation, the patient will be given a message. Given your prior responses, a care team member will be calling you to check in. This is a proposal. We're working to reach out to the National Suicide Hotline team to see if they would be willing to pilot with us so that we can actually send them a message in real time to contact the veteran as opposed to waiting for them to the veteran to call them based on these parameters. So this will help address the concern of needing 24-hour staffing to respond in a timely manner for these asynchronous elements. Now I'm pausing here to just mention quickly Squire 2.0 guidelines. Typically when people say QI and research and the difference, QI you could still publish. It's still a publishable element, but the Squire 2.0 guidelines are critical to follow because they clearly emphasize that there are major limitations to generalizability and internal validity. And so you're not prohibitive from publishing or what you find in the QI study, but it's a certain format that needs to follow. So I'll save the rest of the time for Q&A and our panel.
Thank you so much, Dr. Zanetti. Really enjoyed listening to your presentation. I am one who has tried to walk the fine line between research and QI over the last decade in VA. So I always appreciate learning a lot more about it. And I think there's a lot people don't know. So I'm also looking forward to your fireside chat a little bit later today too. So I'm going to open it up now for our panel, and I'd like to thank, again, all of our storytellers for sharing their stories of innovation with us, the stories of innovation that are ongoing, because this is not a short journey here. But I also just want to take a moment to say, VA has an enormous opportunity right now to invest and drive digital innovation that improves the care and outcomes for veterans. And since we have been, talking with our clinical experts here, I would like a moment to kind of bring in our veteran representative. And I also, before we do that, I would like to introduce 2 panelists who you have not heard from yet. That is Michael Borges, who you may have heard from on a previous panel. And then we also have Dr. Scott Sherman with us. So would both of you introduce yourself, and then I will kick off the panel. Michael, I'll start with you. And Michael, I can't hear you. You are muted.
How about that?
Perfect.
Okay. Hi, I'm Mike Borges, and I was on the panel earlier. And my story is I'm a retired Air Force vet. I had 15 surgeries in the last 9 years, and I'm on a VEText group, which is the Veteran Engagement Group in West Haven, Connecticut. And it's a pleasure to be here. Thank you.
Thank you. Dr. Sherman?
Hi, I'm Scott Sherman. I'm a primary care physician and geriatrician at the VA New York Harbor Healthcare System and a professor of population health at New York University. And relevant to this panel, I am the leader or principal investigator on a national consortium of all researchers involved in virtual care research within the VA, particularly the health services researcher, together with Tim Hogan and Donna Zulman. It's about 150 investigators that form what's called the Virtual Care Core.
Great, thank you. Pleased to have you here with us. So Mike, I would like to start with you because we have heard from all of our VA experts here, and I'm sure all of this is a lot to hear. I know you're engaged with VA, but I'm curious, as a veteran, how does it feel to you listening to all of these innovations that are going on? Do they make you excited? Do they make you feel like, this is overwhelming. I'm not a tech savvy veteran. I'm just kind of curious, what is your take on all of this?
Actually, it's great to hear that there are people out there listening to vets and trying to help us. So it's very encouraging.
Great, great. So how would you compare the experience that you've had in VA so far, over, the last 15 years and 9 surgeries? Do you feel like the experience in VA, especially technologically, considering digital solutions, do you feel it's better than you would have received in the private sector?
Yes and no.
Be honest.
I think it's a little overwhelming because the technology is moving so fast, and dinosaurs like myself can't quite keep up, and we're being left behind a little bit. But me myself, I'm catching up.
Great. I always joke that I'm the least tech savvy millennial you may ever meet, so I can totally relate to you there.
Okay.
All right. Thanks. I would like to then transition back over to Brian, who got cut off a bit there in his storytelling. And Brian, I think you were talking about how you engage with all of the various stakeholders in a project, valuing your project managers along with your subject matter experts. Was there more you wanted to say there about how you get your innovation off the ground and diffuse it on a larger scale?
I'll just make it real short. The PM, you need a strong PM. You need somebody who can make sense of the mayhem. You've got a lot of people in that turnstile. You got to build your coalition up front as you plant your first seed. Concept definition is so important. If you don't bring your friends to the table and you don't pursue technical innovation with OIS and OINT at mind, you're going to have a dogfight for the rest of your journey. So make sure that you include those entities and include your veterans. One thing I'll say, Michael, to your point, I sometimes feel that way, and I work in the innovation ecosystem. What I do notice is we do a great job of evangelizing to ourselves. I don't know if we do a good job of letting other veterans like you and I know what's available to us. When I go to VA, I ask everybody, hey, you ever heard of innovation? Do you know about these programs? No one ever knows. Marketing, marketing, marketing. We've got to do a better job at marketing our opportunities to our veterans so they know what they can engage and appreciate.
I agree 100%, sir. Never forget the vet.
Thanks, Brian. And so this next question I have is more general, so I'm opening it up to everybody on the panel who feels they can contribute. Oftentimes when we innovate, we have one of two reactions. One is knee-jerk, and it's just to innovate at warp speed. I have this great idea. I want it done yesterday. I'm so excited about it. I just want everything. I want everything done now. Or you can go into what I call procrastination by planning, where you're over planning, you're not making any moves, you're not getting anything done, you're just so stunted by, am I going to do this right? Am I going to do this wrong? What's the next step? So I'm curious, how are all of you bridging that gap? How are you, finding a happy medium between that? And how have you just approached it? What mistakes have you made? What successes have you had by, finding that happy medium? And again, it's open to anybody. And I will call on someone if no one answers.
So, well, I guess I'll jump in and start. So I draw a hard line with innovation that something isn't innovation if it causes us to do more work on any end, right? It's not. If a patient has to log into 5 different things, if a care team has to log into 5 different platforms and try to figure out where things are, it's not innovation. That's it's a great idea that is creating more work for the team members at the front line. That's my personal opinion, but I also agree that it fits within the quadruple aim that was spoken about earlier, addressing care team burnout. And these are, the evidence is clear. The interface with care teams and patients with the technology component does increase stress if it doesn't pair well with what we're really here to do, which is to create relationships with our veterans, have a better understanding of what they're struggling with, and making sure that the evidence-based care plan actually matches with their goals in life, not just on some outcome standard that we've plucked out of the air, It has to be something that's meaningful to the people we care for. So the design concept of having them as participants every step of the way through is critical. But I would say we're starting somewhere incorrectly if we're saying we're innovating for our veterans and it's not coming from a veteran. It's just my 2 cents.
I would completely agree. I think I've always had the approach of making sure that I get something out to the users of whatever I'm developing, whether that's for clinicians or veterans, as soon as possible, the smallest product that I can to get feedback. The best ideas always come from the users. An example of that might be when we were developing open slot management, which sends a message to the veteran and says, hey, we can find you an earlier appointment. Well, if you think about that, there's a bunch of veterans to send the message to. So our plan was to send a message to a veteran and wait 30 minutes, and then send to the next veteran and wait 30 minutes. And that would take a long time to do that. We had a group of veterans at one of our hackathons, and we presented that idea to them, and they said, no, that doesn't make sense. They said, we want you to send it to everybody. We're used to competing with other veterans. Send that message to as many veterans as you can, and the first person that responds should get the appointment. And if the other ones don't, then that's their problem. And they said, we're usually used to that anyway. We're standing in front of an MSA, and the MSA will say, hey, I have an appointment next week for you. And then they say yes, and they say, oh, someone already took it. So we're used to that. So by listening to the veterans, we're able to develop open slot management in a way that gets to more veterans a lot faster and is able to reschedule appointments faster.
I agree with that, and that's simplifying it. That's simple, just put it out there and let them do it. Simple. Don't overcomplicate it.
The only thing I would add to that, oh, sorry, Dr. Sherman.
No, please go, Dr. McArdle.
The only thing I was going to say, though, one of my favorite quotes from Harry Truman is, if I would have asked what they wanted, they would have said faster horses, and he developed an automobile. So although I hear both of these perspectives, sometimes we are the ones who are thinking of things. Now, getting the veteran involved and making sure that it's going to fit their need, but sometimes we are coming up with innovations that frontline field staff are just, they're so in the weeds, they haven't been able to step outside the box and actually think bigger. So thank you.
And that's totally true. And the Harry Truman quote is great. The other version I've heard of that is in terms of I think it was the iPhone or one of the Apple innovations, is that when asked how many focus groups they did about it, he said, none. It's not people's job to know what they want. It's our job to help figure out what they need. And I think ideally for an innovation, the best kind is one that makes everybody's life easier, gets implemented easily and seamlessly, but so few of them are like that. So we always end up doing a combination of top down and bottom up, sort of starting with the leadership at whatever level, whether it's primary care or the facility director, chief of staff, that kind of thing, but at the same time engaging people who are the users. Because it is such an iterative process. Over sort of many quality improvement / research studies over the past 25 years, this has just been a recurring theme. And I wish that it was easy and quick, but it seldom is.
That resonates, Dr. Sherman. Any of the innovations I was attached to that were successful had a wide and expansive coalition that incited this field, the VISN, VACO, and the veteran, and you had to have that holistic perspective for it to pop, because there's so much culture difference in between those areas. They have to chime together.
I guess going back to depression, I was part of the leadership of the TIDE study for depression years ago, and when we innovated at our site, really what kept things going, I think in large part, everybody was resistant to change, even though up front they were all really happy that we were improving care for depression. But then their work changed, their life changed, sometimes harder, and that's always a really tough sell. So we got in the habit of every month presenting to the team, like, look at all the progress we've made. Here's the additional number of people we've helped this month through our intervention, through our change. Not that this is just some geeky quality improvement project, but look, we're actually getting more people referred for treatment. And that helped, I think, to take care of some of the frontline resistance to change. and even mid-level resistance.
So speaking of, resistance to change, Brian, this might be, focused at you. I especially appreciated when you were talking about, you're going through this long process with Earthy, and you find out that you've, spent a year pursuing this ATO, and now you find out it can just be an MOA. How are you shifting from that, and how are you changing your course, and what skill does it take to be able to have the flexibility to do that? Talk about the frustration, and who were the others that you had to collaborate to then get that done? Because I assume the group that you were working with originally, CTO, is going to look different now that you're working with an MOA. So kind of talk about that process a little bit.
So I would cuss and pray often, right? Every minute of every day. But now, joking aside, I think Earthy was an example of how the innovation ecosystem was operating at a past time. We have come so far. We have learned from our mistakes to great avail, and I love that the innovation ecosystem reiterates itself, or it takes a look at itself every year and goes, what did we do right? What did we do wrong? So I think that right there is what you do, and I think we've done a good job of it. The fact that we have partnerships now, the fact that we write little project charters, that we build stakeholder coalitions. We don't just say, who cares about this project? Oh, it's audiology. Did we think about all the outlying tendrils and other program offices that need to make that pop, say in the telehealth arena? So again, it resonates to me with the concept definition phase. Like, seriously, we have to take a beat, take a breath. There's nothing wrong with doing 4 to 6 months of planning to get something right, so that you don't waste 2 to 4 years downstream when you're already halfway across the enterprise, and now you have to stop because you didn't communicate with those right entities. And lastly, I can just say that this year I finally got my dream, my wish. Every project that I'm involved with, I started day one with OINT and OIS at the table, planting the seed together, and you would not believe the joy. All this VHA banter about how IT is so bad, OIS is so bad. No, you know what? When we respect each other and we bring each other to the table at the right time, everyone has a moment to think. We're not setting the world's head on fire, and now we can march forward with great avail and fewer problems.
For those of you who are, at the facility level, do you ever feel pressure, when Brian is talking about it's okay to take that 4 to 6 months to thoughtfully plan out something and get started? Do you ever feel pressure at your sites that, no, we need this yesterday, we need to roll it out? And how, if you do, how do you kind of bridge that gap between your local leadership and go through the process of innovating thoughtfully?
So I think the example that we have with trying to address depression and suicide is a pretty, key example. We don't want to wait on this. There's intrinsic pressure on everyone to say, every minute that passes, we could be missing something. And having to balance that with the processes we have to go through for security, safety, so that what we're doing fits into workflows and actually supports the veterans and the care teams in a meaningful way. A lot of what you have to do is you have to be a good narrator of why we're doing what we're doing. If that is made clear and you make the effort to explain that to leadership, I think you can strike the balance.
I think it's also greatly affected by what it is you're trying to do and what's the area. My area of research in general is smoking cessation and tobacco control. So if I was trying, it would be very easy for me to say I need 4 to 6 months to develop something, because this is not a new problem. We've been improving care for tobacco in the VA for 20, 30 years at least. But I'm here in New York City, and if COVID was the topic, we were innovating like crazy last March and April as the pandemic peaked and to crazy numbers here in New York City. So if I had said I'll come back to you in 4 to 6 months, they would have moved on and gotten somebody else to innovate.
And so, talking about, your quick innovations with COVID, I'm in Michigan, so I completely understand, having to do things very quickly with surges. If there were innovations that you think lend themselves well to longevity, there are things that worked out well, you want to keep them, how are you going to go about sustaining them and scaling them and making sure that you can continually use them over time and sell them in a non-COVID environment?
So for us, oh, go ahead.
Go ahead. No, Dr. McCarter, please.
So for us, COVID was sort of the urgency that pushed it through, but it's really the longevity and the sustainability is listening to veterans. So COVID got us over the goal line, but then the veteran testimonials. So we have examples of coal miners who work through the night, who sleep during the day. So hearing loss is a chronic condition for the rest of their lives. So if they can't get in to get, a tweak, a fix, a repair, something, then they're going to lose sleep. They don't come in. Then they stop wearing their hearing aids. Similarly, even in urban areas, big cities, fighting traffic, fighting snow. So when we put it out there for COVID, because for audiology, we were ruled non-essential. And so most of our clinics were shut down. It was the only way we could communicate with our patients through VVC. And this gave us actually the ability to get in and adjust their hearing aids. But now you start looking at all the use cases going forward, the OEF, OIF veterans who are coming back with hearing loss, who have full-time jobs. They take, 15 minutes on their lunch hour for us to just remote in their office in a private area. So I think it's continually getting it out there and then having the creativity, the frontline field staff, once you give them the tool, they become very creative. That's at least what we have experienced with ours.
Yeah, as a veteran, Dr. McCardle, I'm waiting for us to figure out how to provide innovation to the working staff. Like, there's millions of veterans out there. There's hundreds of thousands probably that make up part of the employment factor of VA. And those of us who are working and not retired really can hardly ever enjoy innovation. And as far as like that 4 to 6 month, that's a sweet spot. That's ideal, right? With COVID, I remember hearing innovation teams reporting in, we got to shut down, we got to stop, we better knock it off. We're impacting the field. And I went to Dr. Vega and Kit and said, hey, I can't handle sitting on my hands. How do we run to the sound of the guns? And I think it was a beautiful maneuver where the whole of the innovation ecosystem dressed down its complex innovations, because that didn't make sense. To Cole's point, to Dr. Sherman's point, yeah, I don't have 4 to 6 months, but what we did have was we took a beat, we isolated 30 to 40 innovations that were quick, bam, bam, that would actually assist the field. And it was the first time the innovation ecosystem ever expressed a tactical approach to innovation. And I loved the hell out of it, I got to say. It was so awesome to see everybody running to the chase, but not impacting and infecting the front line with arduous, cumbersome innovation that wasn't ready.
I would agree with you. And one of the things that I've shared with other people is my observation during COVID was that everybody had a unified mission and everybody wanted to get stuff done. And barriers were removed to get things done. So it would be great if everybody could learn from the efforts we made during the successes we had during COVID and transition that mission to the veteran and really have the same successes outside of COVID, because a lot of barriers were removed during COVID to get things done. And it was exciting to get things done quickly.
Dr. Sherman, go ahead, and then we'll move to Q&A.
I think this is really the billion-dollar question facing all of us in the VA, that when we wrote our proposal to have this virtual care core, this Center for Virtual Care Researchers 3 years ago, we predicted, by 2025, 25% of all visits might be virtual. Well, we kind of got to that target way ahead of time. The Office of Connected Care says that video visits increased at 18 or 1900% over the course of the year. So, and the challenge is the genie is never going to go back in the bottle entirely. We're not going to go back to video visits being a rare thing, But at the same time, I'm very, very mindful, and so are, I think, is everybody across the VA, of what Michael said before, is not everybody is accessing these video visits. So the challenge is, how do we go forward with a good number of video visits, but not have this make disparities worse? I see a lot of people over 80, and I can only get about 20% of them to do a video visit, and we've got to get better about that. And there's just disparities in a whole bunch of other ways of using video. So that, to me, is the big challenge for innovation moving forward, is how can we keep these gains, but then make them better and more equitable?
Right.
Thank you, everybody. So we have about 8 minutes or so left in our panel, and I want to make sure that we can get some questions from the audience. So David Atkins, I noticed you had asked a question earlier, and if you're able to unmute yourself and ask the question, I invite you to do that now.
I may have to scroll through the feed to remind myself, because I've posted a couple of questions. I think I really like Cole's presentation, and I love the VEText work. And so, you know, coming from the research side, I'm always looking for opportunities where can we build in some research without slowing down the innovation, but that will collect deeper data than you might otherwise get. You know, so for VEText, we're working on message. We're at the National Prevention Center on messages for vaccine hesitant veterans. You know, it would be a great opportunity, and it probably could be done as QI, not as research, but we could pair you with research, you know, to test different messages. You know, what are effective messages for veterans who have not yet been vaccinated? The strategy that seems most successful is having them talk to their primary care provider. And so, you know, you can think about sending them a message before they have a primary care appointment to say, you know, please talk to your primary care provider to get some information about the vaccine. And then with Cole's presentation, the issue of, you know, detecting suicide, you know, that in itself is an important outcome, and may be enough to, you know, get broad support. But obviously what you really want to do is not just detect suicide, you want to get those people engaged in mental health care. And that's a kind of long-term outcome that probably the innovation group doesn't have the resources to, you know, to follow those people. But we'd love to think about how could we develop stronger evidence to say, not only does this detect more people, but it actually leads to better outcomes. And I'll stop there.
Yeah, so at least for our group, we are going to be measuring that connection feature over time as so that if it triggers that someone has suicidal ideation, you know, what we're still working on is getting connected to the National Suicide Hotline and developing a pilot with them, which is not far into some of the work they're already doing with some applications. But after they're called, the information is all in CPRS, is tagged to their primary care team, as well as their potential mental health team. If they don't have a mental health team, the primary care team is making sure that they're connected appropriately to PCMHI. So we have elements that we are setting up with this. This is early stages, but I definitely appreciate the insight. I think another aspect of QI and research is the nimbleness of QI is a big advantage for the frontline teams. Being able to adapt to what works with a workflow, as opposed to rolling out you know, a protocol to do more formalized research. There is need for all of this, by the way, on both sides. And I think that speaks to, you know, some of what we'll get in the fireside chat, which is, you know, that gray area of how do we really capitalize on both of these components.
Yeah, I would just say that we did do some A/B testing during the peak of COVID, where we were sending hundreds of thousands of messages a day, and we're trying to iterate on our messages to improve the success rate of scheduling back then. And I got a ton of data if you want to talk about it. Now we're only sending like 2,000 messages a day. It's initiated by the facility. One great thing that we did find from analyzing the content of the responses to the message were veterans were interested in letting us know that they were vaccinated already. So by adding 2 more responses to the messages, we were able to collect hundreds of, I think about 300,000 responses that let us know that 300,000 veterans were vaccinated outside, and also pass about another 200,000 were not interested in vaccination. That might be some other data that you might be interested in that we can talk about.
And if I may say so, a quick idea with the suicide thing. Back in 2013, I went back to school. I decided to go back at 50 years old. And one of the things I did was I did a story on PTSD and the suicide rate. And I didn't realize the rate was so high. And I also realized that maybe veterans can help veterans, maybe some kind of program to get veterans trained to help talk to other vets with this. You know, like they're coming up with the AI system now to check markers and stuff. Maybe you can get trained veterans to do the same thing. And sometimes vets like talking to vets.
So Michael, that resonates as a fellow veteran. I met a couple of years ago, I was in DC for a suicide prevention hackathon. And I met a fellow named Tom Cruise, not the Tom Cruise. This Tom Cruise was more powerful. He was Army Special Forces. He wasn't an actor. And everybody was clamoring around him because he had a lot to say, and he almost took his life and his family's life. And now he's an evangelist for suicide prevention. And I went up to him after the smoke cleared and I said, "Hey, Tom, what tool do you actually need?" He said, "You know what I need? I need an app where veterans are all tuned into it, and a veteran can cry out for help, and I could go meet him or her at a bar at 4:30 in the morning. I'll meet them at that point of crisis, which isn't necessarily a clinical approach, but it is something that veterans who have been in situations that may bring peril or may be ideating over suicide, maybe they want to speak to a veteran, maybe they just need to be talked off a ledge." And to your point also, Mike, I know you probably do this. A lot of us hang out on social media on our war era sites, and we like stand watch, and we'll help each other out, won't we? We'll talk people off the ledge every night. I wonder if VA is doing anything to scan social media for suicidal ideation. I'll stop there.
So I could speak a little bit towards this, but I also want to be mindful of time. So I'll be very brief. CareCentra, the application, one aspect is this thing runs in the background. You literally don't have to do anything. After you log in, it just does its thing and sends you nudges. But with their postpartum study in the RCT, they actually created a support group for the postpartum cohort based on their request, actually, which I'm a big proponent of that. So that is something that we're actually already considering for this initiative, that we will create a support group for veterans that are tied into the app to be involved and to provide guidance to us on what they're looking for to facilitate those interactions. So what you guys just described is exactly where we're hoping to go with this. And you know, if you're interested, reach out to me, and we can definitely get you involved in that thought process.
Definitely. Thank you.
Thanks, Dr. Zadetti.
Thank you. Yeah, thank you so much, everybody. This has been a really great panel. I've enjoyed hearing all of your perspectives, especially you, Mike. I'm very grateful you're able to join us. And as everybody in VA would say, thank you so much for your service to our country and all of the insight you continue to share with all of us. Much appreciated.
Thank you, ma'am.
So as we move, thank you. So as we move into the next phase of our day, we're going to be seeing Dr. Zanetti and Dr. Sherman a little bit more here. They're going to be having a fireside chat about combining research and quality improvement for evidence generation and successful veteran-centered digital health innovation. So I will throw it on over to them.
Scott, you got all that?
Thanks very much, Danielle. Yep. Thanks very much. It was great hearing your talk. How do you want to start this? Do you want to have ask me questions? I loved your talk. It was really great to hear what you went through with that.
Yeah, I think that you have some really valuable insight into that gray area between QI and research, and the benefits and drawbacks through some of your experiences. I would love for you to kind of touch on some of those experiences so that we can dive in a little bit more.
No, thanks. It is such an interesting area, and one that I really feel like I've been right in walking the line for the 30 years that I've been in the VA. And the line has shifted over time too. Early on, one of what I was always told at the beginning is, if you intend to publish it, then it's research. And I always thought that was a really poor choice of metric, kind of a stupid one in a way, because I was also told early on to never do anything unless you're going to do it well enough to publish it if it turns out to be of value. So whether it was a quality improvement project, a pre-clinic survey that or sort of a clinic data gathering thing, or a research project, we always tried to do it really well and as rigorous as we could. If with quality improvement, that meant asking questions that were reliable and valid, that were part of our routine care. That I think the way that I saw recently that I really like better as a framing is sort of the intent. To me, quality improvement is meant to be relevant to your own system. So if I'm doing a project at the VA New York Harbor, a quality improvement project, that's really meant for our hospital. And it may be that when we do it, we find after the fact that our project seemed to work, and that the approach we took might be relevant for other people too in their facility, which they would have to adapt to their own facility. So in that case, we might decide to go back and write that up. And I think that is a very reasonable way to do it. We would, of course, if we were to write it up, we would likely go to the IRB to say, here's what we did, here's this process we took. You can't, of course, you shouldn't also game the system. We would get people occasionally coming in saying, we never intended to publish this. And you see this pre-clinic survey that's like half an hour long. Well, like, that's not stuff you need in routine care. Versus at one point in primary care, we had a 10-item sort of check-in questionnaire that had questions on handgun safety and seat belts and depression and alcohol, all of which was extremely relevant to what people were doing every day in practice.
Yeah, I think you're hitting a point here where there's a misnomer of you're not supposed to publish QI, which is just not correct. And if you are publishing, it is research. Just because something is, you are getting peer reviewed when you publish a quality improvement initiative. The question is, what is the intent, which is like, it's not intended to be generalizable. It's intended to tell a narrative of a change experience that that a system went through, that other systems may gain insight into when they attempt to do something similar, so that you potentially can pull interventions that were successful, or even monitoring parameters that were meaningful to that change solution right at the start. Now, of course, it might not work, and that's the beauty of this learning experience of PDSAs. But research is not built; it's built to do something different.
I would say that both sides of the line have learned a lot from each other over the years. So early on, when I was doing this, the quality improvement methods that I was seeing were horrible. Somebody would do a survey in the waiting room and get a response from 10% of people, and then say that that was really important generalizable information, and a researcher would say it's not. On the flip side, quality improvement has been wonderful at, as you said, the cyclic iterative improvement. And I think many of us in the research side have sort of learned from that as we're doing hybrid effectiveness implementation studies, sort of how do we implement something? And it's usually not rigidly the research protocol, but it generally has to be adapted as it's implemented.
Yeah, yeah. And I think that speaks to some tools that are insightful in daily practice, such as with quality improvement, we typically are deploying statistical process control charts and looking at living data and as it moves, and what's not, what's considered normal variation from a system level, and what is a special cause variation, and what do we learn from it? Because because we implemented something doesn't mean that was the only thing that happened. So, it gives us an opportunity to use, robust tools that, research is relying on from a statistical standpoint to look at things, but in a living organization and in real time. And I think that's where that gray area, I hope, continues to exist, where research is trying to capture things in real time, and notice the impact, and whereas QI has to live in that state for it to really make improvements. So I guess, would you be able to speak a little bit more towards, like, how is research bridging that gap of being real-time associated?
I think this is one of the fundamental challenges for research. The program officer from my first NIH grant had this wonderful slide that he showed in a talk nationally about the research cycle, where, like, applying for a big R01 or IAR level grant, getting it, doing the work, publishing it, and it's 5, 6, 7 years. And during that one time, I think the people invented the iPad, the tablet, the iPhone, the Wii, all these crazy innovation in the space of what was one grant. And we can't have that for really a learning health system. You can't wait 6, 7 years for every innovation. You need some of that because it does advance scientific knowledge forward. And we've grappled with that in the virtual care core. It's like, all of us who got into this are used to doing those 3, 4, 5-year projects. But at the same time, Office of Connected Care and others are looking for something much quicker. So we helped Office of Connected Care to choose and fund 17 projects over the course of the last 2 years, 6 related to COVID, and then 11, not 11 just in the current fiscal year. And all of those are designated as quality improvement projects, and all of them had to be a rapid turnaround, had to be done within a year, basically. And they were required to do it as not as a research project, but as a quality improvement project. And I think that that's a nice model as well. It's not either, it's not you can only have this or that, but you really want some of both, to the rapid cycle improvement projects to help advance things quickly. And then the super rapid ones, like with Shane was saying with the VEText program, you could, if you're sending out thousands of messages a day, you can pretty rapidly do improvements the way that Google or others would sort of do the sort of changes over the course of a day or a few days. To wait a year or even 4 years would be crazy.
Well, I also see, like, as you're going through those PDSA cycles and you're learning these different insights, that's where hypotheses and new research opportunities are I think, meaningfully going to come from too. And I think it would be an interesting tie to be able to say, hey, QI projects within the VA, fantastic. If you identify research opportunities, what kind of pathway can we create so that it can cross the line, if you will, to support the areas that we really need more generalizable knowledge to advance.
Absolutely. One of the big challenges I also have always found is that with a system like the VA with 150, 200 facilities, each implementing things on their own, essentially each doing their own quality improvement in real time, we're really great at fostering that. A lot of edicts are top down and every facility is left to figure out how to do better on performance measures or on the next thing. but we're not as good at systematically identifying the best approaches and getting and getting them out to the field and getting them up to scale. Because I find clearly that I am making the mistakes that other people have already made, and that's not as efficient as we could be. So that that's always a hard challenge for any big system, to get sort of best practices out as quickly and broadly as possible with the toolkit to do them.
Right. Yeah, I've seen similar struggles with what were identified best practices for major health systems. There are the sepsis package from so-and-so academic center, which I will not name. And the deployment was actually very challenging. You know, that's when we start baking in health, you know, the implementation science component, and where's the needle here? How do you thread the needle between implementation science too and some of the quality improvement efforts? Because there's rapid adaptability that needs to happen in that area as well.
And even then, adaptability is good, but one of the things we've learned in our studies over the years, early on, one of the big health services research funded studies I did, which was quality improvement, implementing smoking cessation guidelines using quality improvement. We let every facility choose from a huge range of things that they wanted to focus on. And not surprisingly, in retrospect, it sort of got nowhere because people didn't always choose all that wisely. They chose things that were not likely to move the health for the population. So we've been much more towards, you know, here's the stuff you can't change in this package, but you can change this part and this part. And so let's figure out how to implement this quickly while keeping the core, the part we think is the most effective, unchanged.
Perfect. No, I think this is really getting to the aspect of the gray area and how we can actually better partner between these two. And, you know, I hope we have, you know, continued conversations on how we can improve that dynamic.
Absolutely.
Fantastic. Cole, Scott, this was a great conversation, and what wonderful bookends to the day. We had Dr. Ramoni and Beth, Dr. Ripley, sorry, kick us off earlier today, and then you two sort of land some of the same themes, and really appreciate your discussion, really appreciate your time. Thank you so much for sort of rounding out a terrific day for us. You know, and the themes that we've heard through the day are powerful and really provide strong calls to action for all of us. You know, we've talked a lot about the need to move fast and fix things. We've talked a lot about the fact that being veteran-centric or clinician-centric is simply not enough. We have to take a yes and approach. We have to be both veteran-centric and clinician-centric. We need to work in teams. We need to collaborate. We need to reach out and seek our partners to do the best work possible. And we have to keep our eyes on the North Star. And I think that, you know, right at the beginning of the day in her keynote, Dr. Clancy reminded us that, you know, the work is hard. We may need to course correct along the way, and we mustn't give up. That's absolutely right. And at the same time, we also mustn't be satisfied that solutions that simply don't make the cut, that through evidence, whether that's research evidence or whether that's QI evidence, we can't demonstrate that we are improving the lives of veterans while being satisfactory to clinicians and using the best and most acceptable technology generally. And before I round out finally by thanking everyone who's been such an extraordinary part of an extraordinary day, I'm delighted to have Dr. Ryan Vega here on the line, coming in hot from a day in the hospital. Ryan, I know you think about these issues an awful lot. You weren't able to listen into all of the sessions, but we'd just love to have you offer some closing remarks around, you know, what's our call to action? When we think about what good looks like going forward, what do you want to see?
Yeah, it's a great question. I thank everyone who has participated today and apologize I couldn't be with you all. Schedules had gotten changed, and so as you can see, I'm doing my other job. One thing I will say, you know, there's two reasons I love being on service. One, I generally enjoy taking care of patients. But man, there's nothing like coming back into the hospital and realizing the amount of work that we have to do. It took me 20 minutes to try to get into our joint legacy viewer system today, and I just gave up. We've got to be better as an organization. You know, I even myself think that we're doing a great job. And I hear sometimes in the field, we've got all these challenges, but then when I experience them firsthand, it's a staunch reminder that we've got so much work to do. We cannot become complacent. We cannot take, we're working on it, or we're going to get there as an answer. And the opportunity to transform the experience for both veterans and for our clinicians. And the way I like to look at it, it's that clinician-patient relationship. It's my ability to, instead of trying to get into a system for 20 minutes, to take that 20 minutes and spend it at the bedside of a patient. That is a better experience for them. It's a better experience for me. And it's going to allow me to provide better care to them, and in return, them to receive better care. So I know we hear a lot of we're working on it, we're doing this, we're doing that. But the past 24 hours have reminded me that we're not doing enough, and that the solutions that are out there are not working. They're not working for the everyday clinician. Yes, I think we need more data for a lot of our solutions. Yes, I think research needs to play an integral role in proving out the evidence. But I also think we need a lot more innovation. I think it needs to come from the voice of the veteran and the voice of the clinician in the field. And I think we need to continue to push the boundaries despite the obstacles that may lie in front of us. And so in some ways, I'm preaching to the choir. The folks that are on this call are the ones who are doing the heavy lift. But I was reminded the importance of the work today, and I'm reminded of how valuable your services are and how needed they are for us to continue to move forward.
Fantastic, Ryan. Thanks for juggling to make it work to be here. And you're exactly right. There was an incredibly sort of powerful call to action, the need for everyone here on the line to be tenacious. And, you know, one theme that came up through the day again and again before we move to thanks and close out is this is hard work. And you know what? The reality is the work is not going to stop being hard. But what you're sharing with us, Ryan, is that we need to see the best return possible for the veterans we're all here to serve, for our colleagues engaged in clinical care. That hard work has to get the optimum return in terms of improvements that we see. So with that, what an extraordinary day. I'm going to go ahead and just share my screen for a second because there's a couple of things I want to highlight in closing. First of all, what an extraordinary agenda. Thank you to everyone who took the time to, one, join us today and ask important, powerful questions. We showcased 7 important innovations from across VA. We discussed how innovation can sort of begin, whether at local clinics, whether through meaningful, deep, successful partnerships with external vendors, or whether through central offices who have the 80,000-foot view. We had strong, powerful, articulate veteran experts who are able to join us and guide us and remind us of what we're all doing here. And we had experts join us from United Healthcare, from Verizon, and from Google to really remind us of the opportunity we have here on deck. Folks, look at the opportunity that the VA have. Certainly my colleague Smith and I really feel this as we partner with all of you. The opportunity to really reimagine how we do healthcare, the opportunity and the leadership that you show. Thank you so much to everyone on this agenda. And in closing, I just want to say thank you so much to the Symposium Planning Committee with representatives from the Office of Innovation, with representatives from the Chief Technologist's Office, and from I'm going to get the acronym wrong, HSRD's office, the research office. This was a powerful example of showing, not just telling people what it means to do high quality innovation. So thank you everyone on the line. You all get to meet my colleague Smit Patel, who is doing the hard work behind the scenes here, both with planning and with running the show today. Smit is our Director of Clinical Digital Medicine here at DIME. Thank you, everyone. This is just the beginning. As we said, the planning committee is committed to using the learnings you shared with us today and putting it into action with our colleagues. So thank you so much. Have a wonderful day. Be safe. And let's continue doing hard work together that yields the greatest impact possible.